we're going to start with a 2x2 table, and what we want to do is just talk about some terms that you're probably going to hear over the course of the next couple of days and make sure we're all generally on the same level. So I apologize for starting with a 2x2 table, but if we look at an experimental group on the left and a control group on the left side, we're looking at an outcome that either occurs, an event, or it does not occur. This outcome for us is going to be a dichotomous outcome. That is, it either occurs or it does not occur. And then we're just going to fill in some numbers and we're going to work from this table. So the first question to ask is, but what is a study event? The occurrence of a study outcome, which can either be the primary outcome, the secondary outcome, or can be an adverse type event. So in this case, we're talking about non-union or infection or reoperation is generally termed a study event. The adverse outcome can be an adverse event as well. So when we talk about event rates, we're talking about the rate of occurrence of the study outcome event in a group. So if we go back to the 2x2 table just for illustration, we're going to say, and I'm an orthopedic surgeon, so I apologize to all those who aren't, but we're going to talk about a nail on one group and a plate on one group, and our primary outcome event in this case is going to be infection. And you can see that we filled in some of the numbers. So the nail event rate is going to be 10 out of 100. The plate event rate for infection is going to be 20 out of 100. Right. So now, let's talk about how to talk about these results. Department of Redundancy. So results can be presented as relative risks, relative risk reduction, odds ratios. These are dichotomous results we're talking about. Absolute risk reduction, and the number needed to treat. Who's heard of those? All right. So in general, the top three are proportions, and in general, the bottom three are more of natural frequencies or numbers. So let's start with the relative risk. The ratio of the risk of an event in the experimental group versus the risk of an event in the control group. And if we look at this back at our 2x2 table, this would be the infection rate in the nail group versus infection rate in the plate group. So that would be 10% over 20% or 0.5. So if we say that in words, the patient is half as likely to have an infection in the nail group as compared to those in the plate group. If the relative risk is equal to 1, that means that there's no difference between groups. And by convention, if the relative risk is less than 1, so 0.5, 0.6, it's often expressed as the relative risk reduction, or 1 minus the relative risk. Yeah. So if we have a relative risk of 0.5, the relative risk reduction is going to be 1 minus 0.5, or 50%. And if you say that in words, nails reduce the risk of infection by 50% when compared to plates. So that sounds pretty good. But what's the problem with relative risk? If you have a study that says, hey, you know what, if I give you a nail, you're going to have a 50% reduction in your risk of infection as compared to a plate. What's the main problem saying that? It sounds great. Why would anybody choose a plate over a nail or anything like that? The problem is, relative risk doesn't necessarily take into account the baseline risk of you. So if your risk of infection, for whatever reason, is 2%, or the incidence rate of infections overall is 2%, a 50% reduction in risk is going to mean that your risk of infection is now 1%. And then the question you have to ask yourself, is that a clinically important reduction in risk? So relative risk doesn't necessarily take into account the baseline risk of either the outcome event or the patient. Now let's talk about odds ratios for a quick second. Ratio of the odds of an event. So odds is the ratio of those having an event to those who do not have an event. So if we go back to our 2x2 table, the odds in this case would be what? The odds of having an event in the experimental group would be 10 over 90. So the odds of an event in the experimental group is 0.1, and the odds ratio would be 10 over 90, 20 over 80, there, and would be 0.44. And so, but what does that tell us? So the big issue is when you read about people who study how people present these results, oftentimes clinicians understand better risks and relative risks. And if you're a gambler, then you might better understand odds. And so oftentimes we're using odds to approximate relative risk. When does the odds ratio approximate the relative risk? The odds ratio approximates the relative risk when event rates are low. And why use odds ratio over relative risk? Well, if we have studies that are retrospective and we don't know the N, we can't calculate relative risk, and therefore using odds ratios to approximate relative risk. So odds ratios approximate relative risk when event rates are low, or if we can't actually calculate the relative risk. Some argue that using odds ratios purely as opposed to relative risk may over or underestimate treatment effects. But again, it seems that clinicians understand relative risks and gamblers understand odds a bit better. Now, if we talk about absolutes, the absolute risk reduction is the absolute difference in outcome rates between two groups. So the incident rates are 10% and 20%, so the absolute risk reduction is 10%. So this number is a little bit dimensionless, but it's kind of important. And why is it important? Because we can use it to calculate the number needed to treat. And who uses number needed to treat when you're treating patients? Anyone? So if we're calculating number needed to treat, it's the number of patients who need to be treated over a specific period of time to prevent one bad outcome. So in this case, the number needed to treat would be given by 1 over the absolute risk reduction, and it would be 10. So if you say that in words, for every 10 patients I treat with a nail, we can prevent 1 infection. To me, you know, as a clinician, that makes sense to me. Oh, okay, so if I treat 10 patients, I'm going to prevent 1 infection. That makes sense, as opposed to similar things, relative risk reduction of 50%. So number needed to treat is argued to be clinically useful, easy to understand, and it kind of hits home and brings things down to the patient level. So the question then becomes, given the fact that we've got these different ways to present results, how precise are these results? And we talk about the terms being accuracy and precision. Accuracy being how close we are to the truth, and precision being how close the measurement estimates are to each other. And how do we measure precision with these? It's with confidence intervals. And if we take this right out of the Dahl-Carney text, it's a range of values around the sample estimate, so the relative risk, the odds ratio, or absolute risk reduction, within which there is a reasonable confidence that the true but as yet unknown population value lies. By convention, we use a 95% confidence interval. And said another way, basically we're 95% confident that the truth is somewhere within these confidence limits. But there's a 5% chance that we're wrong. So being an orthopedic surgeon, not a statistician, that makes sense. There's a 5% chance that in actual fact the truth is outside of these confidence limits. And this, in turn, corresponds to our p-value of 0.05, which we'll talk about in a second. So the p-value, if we set up our 2x2 table with the truth at the top, yes, there's a difference between groups, and our experimental study finds a difference or does not find a difference on the left-hand side. So alpha is the probability of a false positive, the p-value, and beta error, and beta is the probability of a false negative. So finding no difference when in fact there is a difference. So by convention, you often see a p-value of 0.05, and that's used as being statistically significant. So there's a 5% chance that in fact we're finding a difference when there isn't one. And so you have to ask yourself, well, is that 5% chance significantly different than a 6% chance, or a 4% chance, or a 7% chance? But in general terms, there's a 5% chance that the study is wrong in concluding that there's a difference when there isn't. And what about beta, the chance of finding no difference when there is? By convention, it's set at about 20%, and power, is 1 minus beta, and that's set at 80%. So the power of the study is, will the study find a difference when in fact there is? P-values are commonly reported, but the question is, they tell us that the groups are different in a statistical sense. But they don't tell us anything about the magnitude of the treatment effect, and they don't actually tell us anything about the precision of this treatment effect. Whereas and they don't tell us anything about the clinical significance of the effect that we're seeing. Confidence intervals, on the other hand, help us to see the magnitude of the treatment effect, the direction of the treatment effect, and determine clinical significance. Let me just give you an example. So, here's a tibial shaft fracture. We have treatment A versus treatment B for tibial shaft fractures. The p-values would tell us, well, treatment A is different than treatment B, and we have a 5% chance of being wrong in our conclusion. Whereas, if we say Well, the relative risk, or the point estimate of effect, of treatment A on non-union is 0.4, with 95% confidence intervals between 0.2 and 0.6. That means there's a relative risk reduction of 60% in some outcome event with treatment A versus treatment B. And if we present that pictorially, using this sort of inverted forest plot where 1 is the line of no effect because we're talking about relative risk, so the relative risk equals 1, there's no effect. You can see here is our estimate of treatment effect, 60% reduction in risk, and our confidence intervals are 0.2 to 0.6. The confidence intervals do not include 1. We know then there's a statistically significant difference between groups. The confidence intervals tell us, well, there's a magnitude of treatment effect, and it's really tight. That means the range of values around this treatment effect of 0.4 or 60% risk reduction is actually either 0.2 or 0.6. So we're pretty tight in there. And the thing is, if my level of clinical significance is set here, so for instance, for me to adopt treatment A in my algorithm, I need, as a clinician, based on my past experience in the literature, a treatment of effect of at least 10% reduction in risk of something. We can see here the confidence limits don't include my 10%. Therefore, this is a clinically significant value. That means the risk is greater than my threshold for treatment. So the confidence limits and the point estimate tell us the magnitude of the treatment effect, how precise the treatment effect is, and it tells us the direction of the treatment effect. We're favoring treatment A.